Question 1. A 58-year-old postoperative patient suddenly developed sharp pleuritic chest pain, tachycardia, and dyspnea. His oxygen saturation drops to 86%, and the pain worsens with deep inspiration. ECG shows sinus tachycardia but no ST segment changes. Chest X-ray is normal. Which diagnosis is most likely? The correct answer is A. Pulmonary embolism. The sudden onset of pleuritic pain, hypoxia, tachycardia, and a normal chest X-ray in a postoperative patient is classic for pulmonary embolism. Myocardial infarction is less likely because chest pain improved with leaning forward and ECG lacks ischemic changes. Pneumonia usually presents with fever, cough, sputum, and infiltrates on chest X-ray. Aortic dissection causes tearing pain radiating to the back with pulse deficits, which are absent here. Question 2. A 62-year-old woman presents with crushing retrosternal chest pain radiating to the left arm. She is diaphoretic and nauseated. ECG shows ST segment elevation in leads 2, 3, and AVF. Troponin 1 is elevated. Which feature most helps differentiate MI from PE? The right answer is choice C. ST segment elevation and troponin rise. A focal ST segment elevation in the inferior leads together with a rise in troponin is the strongest indicator of an acute myocardial infarction. These findings are highly specific for MI and are not typical in pulmonary embolism, except in rare massive cases that cause right heart strain, but still do not produce focal ST elevations like an MI. Hypoxia in choice A can occur in both pulmonary embolism and myocardial infarction, so it does not reliably differentiate the two. Pleuritic chest pain is more characteristic of pulmonary embolism, but it does not differentiate MI from PE in this patient because her pain is not pleuritic. Tachycardia is common in PE due to hypoxia, but it can also occur in MI from sympathetic activation, so it is also not specific. Question 3. A 72-year-old woman presents with fever, productive cough, and right-sided crackles. She has pleuritic chest pain and elevated WBC count. Chest X-ray reveals a right lower lobe infiltrate. Which condition best explains her symptoms? The correct option is C. Bacterial pneumonia. Fever, productive cough, leukocytosis, and a focal infiltrate on X-ray are classic for bacterial pneumonia. Pulmonary embolism rarely causes productive cough. X-ray is often normal or shows wedge-shaped infarct. In contrast, myocarditis causes global ST changes and heart failure signs, not lobar infiltrates. Meanwhile, myocardial infarction causes substernal pain and ECG changes, not fever or lung infiltrates. So pulmonary embolism, myocarditis, and myocardial infarction cannot be the answers. Question 4. A 60-year-old smoker presents with substernal chest pain that worsens with exertion but does not change with breathing. He is diaphoretic. ECG shows ST depression in leads V4 to V6. Troponin is mildly elevated. Lungs are clear. Which diagnosis is most likely? The option that fits best is B. Non-ST elevation myocardial infarction. Exertional chest pain, diaphoresis, ST depressions, and elevated troponin clearly point toward non-ST elevation myocardial infarction. On the other hand, pneumonia usually presents with fever and localized lung findings rather than ST depressions. Additionally, pulmonary embolism typically causes pleuritic pain and tachypnea, not exertional chest pressure with ischemic ECG changes. Likewise, bronchitis is characterized by cough and wheezing, not elevated troponin or ECG evidence of ischemia. Hence, pneumonia, pulmonary embolism, and bronchitis cannot be the answers. Question 5. A 70-year-old man presents with sudden shortness of breath, chest discomfort, and dizziness. His blood pressure is 85/60, heart rate is 130, and oxygen saturation is 84%. Chest X-ray is normal. ECG shows sinus tachycardia with a new right bundle branch block, which is the best immediate management. The correct answer here is D. Systemic thrombolysis. This patient presents with sudden dyspnea, hypotension, hypoxia, a normal chest X-ray, and a new right bundle branch block, features that strongly suggest a massive pulmonary embolism causing obstructive shock. Consequently, massive PE with hemodynamic compromise warrants urgent systemic thrombolysis to rapidly break down the clot and restore pulmonary blood flow. In contrast, IV antibiotics are intended for pneumonia or sepsis and do not address abrupt cardiovascular collapse with a clear chest X-ray. Likewise, IV nitroglycerin would further lower the already low blood pressure and is used for ischemic chest pain, not PE. Furthermore, emergent percutaneous coronary intervention is reserved for acute myocardial infarction, yet the ECG here lacks ischemic changes. Therefore, IV antibiotics, IV nitroglycerin, and PCI cannot be the correct options. Question 6. A 33-year-old woman presents with dyspnea and chest pain. D-dimer is elevated. CT angiography is normal. She continues to have tachycardia and hypoxia. A ventilation perfusion scan shows multiple segmental mismatched perfusion defects. Which condition most likely explains these findings? The correct answer here is D. Acute pulmonary embolism undetected on CT. A normal CT angiogram does not fully rule out pulmonary embolism, particularly when emboli are small, peripheral, or obscured by motion artifact. Meanwhile, a ventilation perfusion scan demonstrating multiple segmental mismatched perfusion defects is highly specific for PE, even in the setting of a negative CT. When this is paired with an elevated D-dimer, ongoing tachycardia, hypoxia, and clear mismatches on imaging, the picture is strongly indicative of an acute pulmonary embolism that simply escaped CT detection. On the other hand, chronic pulmonary hypertension typically produces matched perfusion defects or diffuse perfusion reduction rather than several new mismatched areas. Similarly, sarcoidosis primarily involves the lung parenchyma and lymph nodes, and does not lead to multiple segmental perfusion mismatches. In addition, acute respiratory distress syndrome is characterized by widespread infiltrates and matched ventilation perfusion scan abnormalities, not sharply defined mismatched perfusion defects. Thus, chronic pulmonary hypertension, sarcoidosis, and ARDS cannot be the correct diagnoses.